Hello, this is Anne DeGheest. Welcome to the Anne Insights channels on YouTube. First, I'd like to thank you all my supporters who posted my videos of October the 9th, and we have reached over 1,400 viewers. This week is going to be even more important that I get your support. Unfortunately, the US now has reached a point that it's its worst daily cases ever at over 75,000 cases per day. And we also have a lot of information with two videos this week. The first one is on epidemiology, which is showing how the virus is spreading in Europe and a lot of lessons we need to learn. For the US, we're going to do a deep dive in the US and what's happening at the state level. And also we're going to discuss the future of the workforce post-COVID and what could be some of the changes happening to all of us. The second video is going to be very important too. We're going to review all the different treatments if from a preventive point of view, if you have a mild cases at home, and if you unfortunately end up in a hospital with a medium to severe case. So please help me again. We really need to reach out to as many people as we can to stop the spread of this virus. Thank you so much for your support. Hello, this is Anne DeGheest, and this is Anne Insights, and this is my second video on the clinical videos on October the 23rd. Lots to talk about this week. Please do not miss my first video where I talk about the fact the US now has its worst day today on October the 23rd with 79,000 cases. And there's an explosion in Europe that could be predictive of what may happen to us. So we need to learn the lessons from there. Today, I'm going to be reviewing all the different treatments that you could leverage and what are the protocols right now that we have learned so far if you have mild cases of COVID or if you have severe cases. For people who have not been here before, take a look at my August 7 videos there where I go into detail about all the different symptoms of COVID, which unfortunately, there's a long list of them. The most common one is to have a fever. Keep in mind, in New York in the spring, 70% of people going to the ER that got admitted didn't have a fever. Loss of taste and smell happens in 2/3 of the patients there. So go take a look at that video. Risk of infection. I want to remind people that your chance of being infected is a function about the amount of viral load you got exposed to, so at the time the person is infected, multiplied by the time of exposure. And that has been shown to drive the risk of severity. And it's important there because the CDC today just this week changed their definition of the 15 minutes. It's no longer 15 minutes in one shot. It could be 15 minutes several times during the day that basically toll to 15 minutes. So I just want to reinforce, it's not a one block of 15 minutes. It's an accumulation of time that will add up to 15 minutes. Being enclosed indoors increase your risk. Poor ventilation increase your risk. Being in a crowded environment, close to a person less than 6 feet, and no mask. So if you're interested in here, look at my video on September 25th. We do a deep dive on ventilation, the difference between the droplet versus the aerosol. The fact that in low humidity there, you may have this aerosol that lingers for hours in the air. So you need to be aware of your environment. The 6 foot and is not a safe metrics for you. You need to be aware of where you are and what type of ventilation, and especially air conditioning ventilation could put you at risk because it recycles the air. So another thing I want to remind people, during the influenza, which is coming up this winter there, people get infections and sick very quickly there. The reason why we're having a problem with COVID, it can take up to 3 days from the time you get infected for you to basically have your symptoms. Ironically, your peak of infection is before you get your symptoms. And that's the problem we're having right now. A lot of parents are getting infected by the kids going back from school. And remember, up to 80% of the kids are asymptomatic. And if their symptom is so mild, they're probably not even aware of it. But they are 5 to 10 times more infectious, which means they pass it on to you. And by the time you get tested and you test them, they may no longer have the infection in their body there, and the PCR may be negative and you're positive. So you really understand the dynamics there. So a quick reminder there, around 80% of people are, asymptomatic or mild, 20% roughly end up maybe having to be hospitalized there. This is period of 7 to 10 days. You really need to be careful there. That's when you want to monitor yourself if you have turned positive. And then, you know, there were a whole bunch of treatment we're going to talk about what happens when you have that cytokine storm response, and unfortunately that drives you to the hospital there. So we'll talk in more details in all this phase, but be aware that if you got infected, which a lot of people, a lot of us may get infected there, you have to manage the transition there. This is what makes the big difference, this period there. So the immune system, we have talked about the B cells and the T cells. It's turning out that the vaccine is trying to create these B cells, but we're learning more and more that these T cells is the one that may be something that helps us. And these are the historical memory of our immune system. And since a third of the common cold are related to the coronavirus family there, we are discovering a lot of people have very mild symptoms because they have these T cells that has been built over the years. And if you want a deeper dive on a lot of those things there, please go take a look on my August 14. We spent quite a bit of time on the immunity there. So let's now, assuming you have some good understanding of that, we're going to differentiate between the innate immunity, which is your first set of response in the first few days, and your adaptive immunity, which is the one at 7 to 10 days that's so critical. So what are some of the good news, bad news? On the good news side, I'm looking for good news. There's an interesting story of a fishing boat. And the fishing boat, they tested everybody before they left. And everybody was negative using PCR. Okay. And they went on the trip. And when they tested negative, 3 of the crewmen had antibodies. The rest did not have antibodies. So they thought they were safe. Unfortunately, very quickly there, one of the members got very ill, so they had to return to port. The good news, because it was a controlled environment there and we had a baseline, they did a whole genome analysis of what everybody had, and they discovered it was the same virus. So it was clearly a beautiful petri dish, if I can use that term. 88% of the crewmen got infected. Okay, so very contagious. But here's the interesting part. All the 3 sailors that had antibodies did not get sick. And that's really important there because it's the first direct evidence that we have seen that antibody protects you against the SARS. And the data here, for people who really love data there, you can see the 3 sailors there. If you look at their IgG, which is their antibodies there, they basically stay flat. The body protected them. The rest of them, you can see over time, they really build the antibody. That means they were fighting the disease and they built a defense system. So that was good news. Let's look at some of the other news in the world. So the UK is doing a really good job at looking at the genomic of each of these viruses, because right now Europe is at its 4th generation, and the 4th generation is one that comes from Spain. And so UK is doing a good job. And one of the things they did is that there was a dialysis clinic where there was an outbreak. And they start doing the analysis there, and they can see that they were able, as a result of that, to control and do case tracing and isolate it. Unfortunately, the US is doing a very low amount of sequencing of the genome. So we don't really have a good idea of what is going and spreading across the country there. The only one case we know is this case in Nevada, where somebody had the virus in the spring, went to Spain, came back and ended up in the ICU because he got sick with a different mutation of the virus there. But most of the time, we don't really have a good analysis there. So we really need to get the US to do more genomic analysis so we understand what's happening, because it's important for contact tracing to see who gets what. Another concern that has emerged is what's called ADE, which is antibody-dependent enhancement. And what that means is that could you get sicker the second time we get infected or exposed? And there is a certain type of reaction that has happened with what's called dengue fever, where the first time you get infected, you get a certain amount of antibody. And then somehow this antibody acts against you the second time you get exposed. And the reason why it's a concern is that there has been study done in Petri dish, and what they can see is that we're having the same response for the second time. So that's something we need to keep an eye on, because this virus is going to come back in cycles like the flu is. And so the concern there is that if you get the vaccine, you're going to create antibodies, and we want to make sure that when you get infected by the virus, you don't have a stronger response, or at least a subpopulation gets a higher reaction that they could have had if they had no vaccine. That is why it's critical that we have enough data of people who take the vaccine to see what happens when they get exposed to the disease. Do they get a stronger reaction? So that we have longitudinal data and safety data to make sure we don't have this situation there. So we need to look at the antibodies of people who have taken the vaccine. And we'll talk more about that. CDC has just come up with some data that shows that 75% of Americans are overweight. And the reason why it's important there, because people with a BMI over 30, which is obesity, have 2 times higher risk of being hospitalized. And the reason is because the adipose tissue, which is the accumulated body fat, promotes inflammation, which of course COVID love that environment there. And this has come up in New York City there, showing that men, not women, but men have a 1.4 higher risk, so 1.4x higher risk of mortality and the 2 times higher risk of being intubated there. So intubation, if you're obese, you have a high risk of unfortunately being intubated. A British study did a similar study in parallel. So 2 studies came at the same time on 380,000 patients, and they show a 30% higher hospitalization rate, and again, a 2 times higher risk. So clearly, please lose weight. I'm not sure it's something we can do quickly there, but it's in the back of my back burner. Another study came out from Holland where they look at the mortality at 21 days. From 10 Dutch hospitals there with over 2,000 patients there, some people who were in the ICUs and some people on the floor. And pretty much what drives the outcome and mortality was age, not a surprise there. But this is what came out, number of medication, which is another way to say you have pre-existing conditions and you're being treated at. But this is a new one. BUN is blood urea nitrogen. This is what measures your kidney function. People who have had a decrease in kidney function, which they may not be aware of it, are significantly higher risk of complication. And the LDH, which is cholesterol. And of course, oxygen saturation, we all know about the hypoxia there. So they believe they have come up with an algorithm that can predict at the time you get admission in the ER if you're going to be at risk of the ICU. And people are starting to put in place, as this new wave is coming and hitting us for the winter, about some triage algorithms to find out what patient at the admission needs to be treated differently than others and who is at a higher risk. Confirmation that blood type A is a higher risk than blood type O, for example, and A and the B types, kind of neutral there. They have identified now 2 locations that is linked to having a reaction to COVID. And for people who love genomics there, I basically put these 2 locations that you clearly see as a big differences there. And that does explain data from hospitals in Italy and Spain, around 2,000 patients there, that, the blood A has a 1.5x higher risk versus blood O, which is around 0.6. Let's talk about our long COVID there, which is people who after several weeks have not recovered, and it is emerging to be maybe the tip of the iceberg, was not fatality, but having this long-term damage. There's a study in London, King's College, just came up with a study there showing that 13% of their patients there had problem after 4 weeks, 4% after 8 weeks. People at risk, as interesting enough, between 18 to 49 years old, 10% of those patients there had those problems, not just the elderly or people end up in the ICU. And it's being older, overweight, women, and asthma was the drivers. And they're developing predictive models. You can really see here that, of course, the age, is increasing the risk, but it's still a risk for people who are younger. As a result of that, the NHS, which is the UK government for healthcare, is now offering long COVID standard one-stop service. I expect this to happen all over the US. We are going to have a tidal wave of people who have recovered when they had mild to asymptomatic cases who cannot go back to normal. And they have multiple problems. They have problems with their lungs, their sleep, cardiac. I mean, we've talked about this in the past. I'm being generous to say it's a minimum of 10%. The CDC has reported it could be as high as 30% in the UK. They put together a COVID recovery app. They get over 100,000, which is similar to the number of people in the US on Facebook. This is an analysis that shows all the symptoms, and people who have the short COVID, i.e. within 2 weeks of being infected there, you can see they have a few symptoms there. And they're not always combined. You get a few of those, but not all of them. If you get the long term, which means at 28 days, you still haven't fully recovered, you can see you have this multiplicity of symptoms there. And we report a couple of, I think a month ago, that it's up to 98 symptoms have not been reported in the US by these patients. So it's, and of course, you can see the odds ratio, which is your higher chance of a risk. People who have any type of kidney problems, have pretty much 2 to 3 times the risk. Obesity, we talk about, is a higher risk. Diabetes is a higher risk. And of course, any type of cardiovascular. This is a new one. Does COVID triggers diabetes? And I'm talking type 1 diabetes. We also know that having existing diabetes increase your chances of death. In fact, 40% of people who die had diabetes. So it's clearly a very strong predictive factor there. But this is brand new. There's been all these cases in healthy people and kids who were totally healthy and suddenly became type 1 diabetic. And when I say type 1 diabetic, it's really a big concern there, because you think you're okay, and then you end up in what's called a diabetic coma, end up in the emergency room, and that's when they diagnose you that your pancreas is no longer working. And it's so concerning there, because there's been all this anecdotal story being reported in people in hospital there, that now King's College is starting a worldwide registry where people are keeping track of all these patients, so we can try to understand why the pancreas is being affected there. In Children's Hospital of Los Angeles, they now are also seeing newly diagnosed type 2 patient who gets into diabetic ketoacidosis there, which could also be fatal there. So we need to keep an eye on that. If you have had COVID, make sure that you watch for any type of sign of extreme thirst, fatigue, and frequent urination, weight loss. That may be an indication you should get yourself checked. Another thing that's getting confirmed is the damage to the heart. We've reported this in the back. A new study just came out. There was a meta-analysis of 9 studies, so over 1,400 patients, showing that between this study, there's between 11% to 27% damage to the heart that was reported, looking at imaging and biomarkers. And we're still trying to understand what is happening to the heart, but we can see in images that there's a damage to the heart muscles and to the heart cells. We believe it's due to metabolic disruption, hypoxia, which basically can kill cells. There's clearly an inflammatory response that we can measure. And as a result of that, it changed the electrical signal, which creates arrhythmias. So more and more data confirming that, even young people there, can be at risk of a cardiac inflammation response. Let's look at the brain. Not to be totally pessimistic today. We've now done pathology and analysis that show that COVID is inside the brain, and it's affecting what's called the astrocytes. And the reason why it's important is that the astrocytes is what's manage your energy metabolism. And it's really essential to fuel the neurons and keep them healthy. And unfortunately, what we're discovering is that for people who have mild to no respiratory symptoms, so the asymptomatic, who are not hospitalized, they're now reporting 28 to 56% of the symptoms. And they've now measured not only anxiety, but cognitive impairment. And when they do the MRIs and the imaging, they find out that the cortical thickness has changed. And the cortex is thinner. And there's data that shows that your memory task and a lot of your executive function are being affected. They start doing autopsy, and 26 autopsy of people who died, and 19% of them had the COVID spike protein all over the brain tissues. Why is that important? Because you can see in these images that you can see the fitting in this prefrontal area there, which is really important there. And you can see here is another way that the astrocyte is creating what's called apoptosis. Apoptosis is a nice way to say the neurons kill themselves. And that's really bad news, because we know neurons don't come back, and you have to now work on brain plasticity to basically, create new pathways there. To give an idea, there's a study that done on people who are asymptomatic, and 72% complain of anxiety there level that was confirmed by testing. This is the more interesting thing. If you look at memories, and memory is called immediate recall. So if I say 1, 2, 3, you repeat 1, 2, 3. Delayed recall, I ask you that in 5 minutes there. And then you have logical memory, the ability to basically follow orders and do a task. What's very interesting is in light blue are the asymptomatics. So this is not just affecting people who may have been intubated and have been compromised being on a ventilator. This is affecting mild to asymptomatics there. So very concerning. We need to keep an eye on that. This is being confirmed. We had our video 2 months ago, we show some of the data from Canada there that show up to 95% loss of memory functions. Why is it a worry? Remember mad cow disease? Us old enough to remember that. Mad cow disease is a prion disease. And it does look that COVID is activating 119 differential proteins that is associated with neurodegenerative diseases. And that's really worrisome if it's a trigger to accelerate something you may have been at risk of, or is it damaging the neurons? Well, you were not at risk before. We don't know yet. Let's change about testing. If you look at the news, there has been a lot of concern about what's called antigen testing. And we discussed this in prior videos. Antigen testing means the PCR is testing if you have a piece of the virus, and that's the one that takes several days. So people have come up with point of care testing that look at the antigen. The antigen is basically a way to measure if you have some type of infection reaction there. And the problem is that between 30 to 60% of this antigen testing can give you a false positive. And Quidel and Becton Dickinson have been sent to nursing home. And Nevada, for example, reported so many false positives that could not be confirmed with PCR that they stopped doing the testing there. So, and so the federal guidance is to say they have lower sensitivity, i.e., they mean you may get a positive case, but you're not really positive. But and so it is a concern there because we're using this type of equipment there in nursing home, and it's not the most reliable system. And I've told you before, nursing home is where the mortality is happening right now. So we need some better testing. So is it the failure of the test or the tested? And Abbott, as you know, has this device called the Binax now, and they're testing the molecule that's on the surface of the virus. And it's very accurate, but there's a very high chance that you may have a false negative in this case. So we have capacity issue. We should do $200 million tests a month. We can barely do 25 million. We are not there. We don't have a way to control the positive rate in the US. So we have to absolutely fix this. In addition to that, the big worry for this winter is that already today, with 29 out of 40 drugs that are being in the hospitals, we're going to talk about some of those, are in short supply. And it's a problem there because the raw materials come from China. They usually are manufactured in India. And what we saw in the spring is that when the world got hit, most of these countries stopped exporting there. So there's a big concern in the US that we may need some of these basic generic, but are critical to intubate you and to treat you in a hospital setting there. The government has set up a new company there, but it takes time to build facility and having them approved by the FDA. Let's talk about COVID. Good news, AstraZeneca and J&J announced today they're resuming trials. They have done some research and they had these 2 adverse events and came to the conclusion they were not due to the vaccine. So that's great news. So the trials have restarted in the US. So, and again, a lot of people believing these are the 2 most promising vaccine types coming at us. I won't spend too much time on this because we did an extensive analysis of all the vaccine on September 11, and we also discussed on October 9, what exactly does it mean to be approved? And that means that the bar is 50% prevention of the vaccine with a variability that could mean that you may still have a 50 to 70% chance of being infected. So the vaccine is not a silver bullet. So would you take a vaccine? And so the data shows, well, it depends. If it comes from the US, the CDC endorsed it, and the data I can trust is 90% effective, yes, I would take it. If on the other hand, it comes from China, it's endorsed by the president, and it's only 50% effective, no, I won't take it. And so right now you see the US is really not maybe willing to take a vaccine, even if there's an early approval. Why is that important? Because yesterday the FDA started realizing that it may not want to do an emergency use authorization. And let me explain you why, because it's really important for you to feel that you can trust the data that's going to come in the next few months. First of all, everybody's trying to get less and less comfortable that there's transparency, that we can trust an FDA approval there. But I think the big issue is that If you do an emergency use authorization, that means you can no longer have a controlled arm of the trials with a placebo. Right now, what they're doing is that if you go into these trials, you may have a 50% chance of getting the vaccine or not getting the vaccine. And that's important because we want to compare the two groups to see safety and effectiveness and long-term issues there. For ethical reasons, as soon as a vaccine is approved for EUA, you can no longer do that. You have to offer the choice to have the vaccine to the placebo arm, which means it will compromise the ability of the other trials to basically enroll people to participate in their trials, because if the one is approved, why would you take a chance of a 50% chance of not getting the vaccine? It will also stop the comparison for the long-term safety data of the first trials. So there's a big concern that it will compromise our ability of really knowing if this vaccine works. And the primary endpoint is just to say you have a 50% prevention of a positive PCR test. But what may be much more important is the secondary endpoints, which is how long does it last? How long are the antibody workings? Do you decrease the severity? You may still get infected, but you don't get really sick. That's important to know. And does it work better in subpopulation than others? It's really critical for us, if we're going to inject this to 7 billion people there, that we have this data. So the belief is that instead of doing EUA, which is very politicized right now, they will do what's called an expanded access. An expanded access will allow the pharmaceutical company to continue to do the control trials with two arms, and one has the vaccine, the one doesn't have it. It just is a bit more paperwork intensive there, because you have to get the patient to sign informed consent, which is, in my mind, not that bad of a problem based on the fact we will know if this vaccine works. Again, if you want to know more about the vaccine, take a look at my October 9 video. Now I want to go about treatment there. We talked 2 weeks ago in deep detail, but I want to spend more time on treatment, about what you should have at home. Please all have a pulse oximeter. It's something I launched 30 years ago. I have no interest in the company now, but it may save your life. Pretty much as a rule of thumb, take a look at your normal sea level should be above 95%. If you're in elevation in Colorado, you probably could be below that, where you're looking for any major drop of 4 to 5 percentage point. So if you go from 97 to 93% and your heart rate starts going up, you really need to get medical help. Vitamins, we talked about last time. All these data have been published on vitamin D3, vitamin C, vitamin B, calcium, magnesium, and zinc. Lactoferrin may inhibit the virus entry, boost your innate immune system there. And NAC can really help the body fight the COVID if it's being exposed there. Omega-3 has a lot of data showing that it could decrease inflammation. And melatonin is getting more and more confirmed. You're going to see that's the treatment they give in hospitals there to decrease the severity risk that you have if you get exposed to the virus. So Eastern Virginia Medical School published a protocol. So I wanted to go over some of it about what's the latest protocol in treating patients there. Prophylactically, they recommend a lot of the things I just discussed. If you end up being infected and are at home with mild symptoms there, it's the thing I mentioned about vitamin C, zinc, melatonin, vitamin D3, also some aspirin to decrease the chance of a blood clot. Remember, these diseases we discussed in the past damage the epithelium there and create blood clots, and you may end up with risk of a stroke or pulmonary embolism. So it's very important that you take the 81 milligram, of course, all under medical guidance. And famotidine, just to protect you if you have a risk of kidney problems. If you end up in a protocol where you become, unfortunately, have to go to the hospital there, I'm going to go into the process of how you deteriorate and how they treat you. If you end up being admitted to the hospital there, what's called mild treatments there, i.e. you're on the hospital floor. Look, it's the same protocol, vitamin C, zinc, melatonin, vitamin D3. So all of that, please take them. And then they start giving you methylprednisone at 40 milligram. This is, what has been the most effective treatment so far in decreasing mortality there. If you get to the next level, which means you're having problem with hypoxia. Hypoxia is when your oxygen saturation drops from 97% to below 93%. It has been reported in hospital, people get admitted with less than 70%, which is unheard of. Methylprednisolone shuts down your immune system. That's because you're having that cytokine storm we discussed in the past there. That has to be highly monitored in an ICU setting there. It's something that you have to tamper yourself up slowly. And they start giving you serious anticoagulation drugs because you are significantly higher risk of a blood clot there. If unfortunately you end up in the full ICU, what they call the full Monty, then they start giving you Remdesivir. Remdesivir is really for patients who are really in critical situation there. Very often you end up developing pneumonia by having fought the disease for a while, so people end up with broad spectrum antibiotics there. If you may get a risk of hypotension there because the body starts getting fatigue, and then most people start getting oxygen support at different levels there. And then if you're the grave ICU, i.e. you're probably intubated by now, they will give you the blood plasma exchange. The data, if you remember, we have visited a few weeks ago, is not clear-cut how helpful that is, but at that stage, we basically give you everything we can think of to really help you recover there. And then the dose of the corticosteroid goes straight up. Remember, we're talking 40 milligram if you're mild, 80 milligram if you're in the early stage of the ICU, and now this is basically really shutting down the immune system there because you're having that cytokine storm. And we start monitoring glucose. Remember, we're getting worried about this diabetes onset. So when you get discharged, it's really important there that you slow down progressively, and it may take several weeks to slowly drop down by 50% every few days the amount of the drugs there, because otherwise these drugs are extremely dangerous. Please do not take at home without surveillance of a doctor, because you could trigger some massive chronic diseases like diabetes and all of that if you don't do it right. And then post-discharge, a lot of the things we talk about the multivitamins we discussed before, the B and the Ds, the melatonin, omega, and then depending, there's going to be a lot of prophylaxis and DVT, which is if you're at risk of developing blood clots. So this is very similar to what we discussed called the Math Plus, which is getting to be the emerging protocol that everybody's talking about across the country there. And this is the president cocktail, which is the methylprednisolone, Remdesivir, Regeneron, famotidine, vitamin D, melatonin, aspirin, and zinc. Okay, so this is what he received. Now, what was unusual about his situation there is that technically he was not in the ICU on oxygen, but they clearly treated him like he was a potential severe case, because otherwise you're not supposed to get any of these drugs. So Eastern Virginia Medical School, which I'll talk more about, that I just shared with you, is basically showing that this is now the cocktail, and they call it Math Plus because it's methylprednisolone, that's the M, ascorbic acid, which is the vitamin C, thiamine, which is vitamin B1, and heparin is what they give you to basically decrease your chances. And then in addition to that, they give vitamin D, zinc, and melatonin. Very consistent now from every direction. It's still being evaluated, but that is the protocol now. That's kind of the standard of care in the US. Let's talk about Remdesivir. Very controversial right now. Several reports have come out. In New England Journal of Medicine, it shows that there's a time of recovery that goes from 15 days to 10 days. Okay, so that was reported a while ago. But is it really improving mortality? No, it's not. It is not by itself. It has to be a combination approach. The only data they show is that you get discharged earlier. And at 29 days, there is no statistical difference in the mortality rate. It doesn't basically protect you for death. And this is the data. You can see that Remdesivir, it basically gets you discharged a bit earlier there. Patient receiving oxygen, ironically, doesn't seem to make a big difference there. And so if you are intubated on a ventilator, there is no difference there. Why is that important? The World Health Organization did a study that just came out a week ago on 12,000 patients in 500 hospitals in 30 countries. This is like as good as it gets. And they evaluated 4 drugs: Remdesivir, hydroxychloroquine, Lopinavir, and Interferon. And what they came out is that none of them affect mortality. And only the corticosteroids have been proven effective on severe and critical COVID. And if we had any doubt about hydroxychloroquine by now, it produced little or no reduction in death. Despite all of that, the FDA yesterday approved Remdesivir under the new brand name of Veklury as the first and only FDA-approved treatment for COVID for hospitalized patients. So I just, the drug is approved. So the good news, it's going to be easier to get, assuming there's availability. But I want you to manage your expectation. It is not a silver bullet in the treatment drugs that we were looking for. And again, this is the data that came out of Europe. And you can see that control versus Remdesivir, absolutely no difference in the mortality rate. Hydroxychloroquine, if anything, it's worse, has a slightly higher risk factor. Interferon, you can see interferon as basically a 1.16 mortality, but it's not statistically significant there. And the Lopinavir, also no difference. So these are massive trials from multiple diversity of demographics. So these are things we can probably trust. Again, I want to thank you for listening to my videos. If you'd like to know more, and I mentioned some prior videos, you can download, there's a link on YouTube for two types of documents. One is a time index, so you can really look per video what are the subjects with a timestamp. And there's another one there that's a lecture by showing by key names where you can look in prior videos. So please vote. We need your help. We need everybody to express their opinions. We really appreciate you listening to this video. I will see you in 2 weeks post-election, and I really hope you stay safe. Please wear a mask and help me post these videos. We are an inflection point. I need all your help to spread the word and the knowledge across the country. Thank you.